John, we're very interested in the Medical Council's plan to use practice visits as a way of assessing performance and competence amongst our New Zealand doctors. How do you see this actually happening, and how many visits and how often will different specialties require to happen in New Zealand if we're going to be assessing the competence of these doctors?
I think it's going to be more than just assessing competence. I mean, clearly that's a key part of it, but I also think it's going to be critical for the practitioner's ongoing professional development, for indicating where there are deficits in their knowledge or practice, and a good means by which practitioners can improve their performance.
How often do you expect each individual doctor to need to be visited at one of these visits?
Well, that's one of the things we'll need to discuss, but my feeling is that it'll probably vary during a person's career. So, given that it takes us 10 years to train, it may well be the first practice visit is 10 years after that, and then maybe a couple of 7-year intervals, and then one at 5 and 5 thereafter.
That doesn't sound as onerous as I think some of the doctors hearing about this idea a wee while ago would have thought.
No, and I think it'll probably be something like 4 to 5 during a person's career. And I think people will find this very valuable. I mean, I don't think they will see it as onerous once they've had some experience of it.
John, have you got overseas evidence that these practice visits will deliver what you expect?
There's certainly overseas experience, and there's experience in New Zealand as well. Evidence is always more difficult. The evidence is that as we age, we don't practice in many areas as well as we did when we were younger. Secondly, that we're not particularly good at picking out the areas in which we're deficient. And then the third evidence is really that those who've gone through the process have almost universally reported it as being a benefit. It's identified areas that they can improve on.
So you see this as a learning exercise rather than just an assessment exercise for the doctors that are going to be involved throughout their career in this ongoing development?
I think they're primarily formative, and the more they can be handled by the profession within the colleges, the better. And I would only see council being involved if there was really a danger to public health and safety, something really immediate and urgent, or if the person, once he or she had gone through the process, was not really making the adjustments to bring their practice up to good quality.
That sounds heartening. So what you're anticipating is that it'll be the colleges or branch advisory bodies that would do this as part of continuous professional development?
Yeah, I think it's part of the quality improvement movement. And I think it's got to be led by the profession, it's got to be organised by the profession, and I don't think a body from outside, such as the Medical Council, can impose this on the profession. Otherwise it would be extremely difficult to implement, and I don't think it would meet the purposes for which it's designed.
As you're aware, some of the colleges would claim they're already doing much of this already. How are you going to empower and encourage those colleges who aren't doing this to the level that you at the Medical Council feel needs to happen?
I think the experience of the colleges that are should be pretty influential. And I think what the council would like to do is to take it through the continuing professional development line and say to the colleges, we already do peer review, we already do audit. Can we introduce practice visits here as well as part of your recognised CPD program? And I think there'll be acceptance of that in the profession.
The visits that currently happen under various colleges, professional ongoing development, have different lengths of imposition in terms of time and taking doctors out of patient interactive time. How do you see dealing with the requirements at different specialties for the amount of involvement there might be in a practice visit?
I would hope that the visits would be able to be done within the day, and I think that's the experience from the obstetricians and gynecologists, because you're actually gathering information before that. For example, through the review by a person's colleagues through a 360-degree review. And then the person would also assemble any audit data that they had for review as well.
I guess the individual doctor hearing what the Medical Council is planning to do is going to be concerned about the increased demands on their time for more bureaucratic reporting, as they might see it, to prove that they can still do the job that they might well feel they're capable of anyway. So how are we going to deal with that worry that this is a timely imposition?
Two things. One, the time. Two, the bureaucracy. Time is an important one. I think, given that we're all spending time on continuing professional development, we're going to conferences, I think if one is looking at doing this once every 5 to 7 years, and maybe being involved in a review, being the reviewer, which is also educational, a couple of times in that 5 to 7 years, then I think that amount of time is a good trade-off against one of the conferences that one goes to in a year. And then the bureaucracy. I think we have a bureaucratic system now where we fill in these points and mail them in, and it's a scramble at the end of the year to remember which ones you've actually done and got. I think this is a far more effective scheme of ongoing education.
And these visits will be done by our peers?
I think that's very important. I think it should be done by people in the same specialty and as much as possible in the same areas of practice. So rural practitioners do rural practitioners as much as possible. Because, as I said earlier, I think one of the important aspects is that this is educational for the reviewers as well as the person being reviewed. I mean, all of us who've been on accreditation visits know how much we learn from that and take that to our own practice.
The Medical Association certainly acknowledges, as we all do, that the practice of medicine is much more complicated than it used to be. And if we're going to be part of the medical profession, we need to accept that learning is an ongoing exercise. If these practice visits are going to enhance that learning process, then they should be eminently saleable to the profession. Is that your understanding, John?
I think that's very important. And I think if it's driven by the profession, that will increase the uptake. But it will also prevent it coming in and being imposed on the profession from outside, which would be really difficult to handle.